Hi everyone, I'm Ann Spinard, and we're going to spend the next hour talking about changes in skin integrity, the post-acute care, pressure ulcer, and injury, M1311. So just to explain, we'll do an hour, then we're going to break for lunch, and then we're going to come back. We'll do some coding scenarios and a debrief, and then we'll do some closing slides for about a half an hour when we get back from lunch. So this session straddles some time. In your folders, you have a coding scenario packet. I think there was one started off with J. It says coding scenarios day 1. For those of you on the web, you can find that in the March 2019 Home Health QRP Provider Training Day 1 Part 2. There's a handout there, and you may want to print that out. We're going to go through some Slido slides with scenarios where you'll be using your phone to answer them. And then after lunch, you actually will be doing some your own coding individually, and then we'll come together as a group, and you'll need that packet for that. All right. So as we start off, we have our acronyms for our presentation here. So if there's anything that you're unsure of, you can go to your acronym slides. There's 2 of them. And so let's talk about the objectives for today. So we hope by the end of the session that we'll be able to have you describe the modified cross-setting pressure ulcer injury quality measure, so you'll understand that measure and how it is calculated. We're going to articulate you'll be able to articulate the rationale for changes in M1311 and any implications for coding, and then apply the coding instructions to accurately code the practice scenarios. So that's for today's session, but hopefully you'll take away this knowledge, be able to educate your staff when you go back to your organizations, or for those online, use these as some training materials, and the idea that we will all be accurately coding the OASIS. So let's talk about changes in the skin integrity and the quality measure description. So this quality measure reports the percent of quality episodes with reports of stage 2 through 4 pressure ulcers or unstageable pressure ulcers/injuries due to slough/eschar, non-removable dressings and devices, or deep tissue injuries that were not present or were at a lesser stage on admission. So that's the definition that we are going to be working through in all of our examples as we move forward today. So let's frame what the quality episode is. So the quality episodes are defined as by pairing a start of care, or a SOC, and the resumption of care, a ROC, assessment with an assessment completed at discharge. So that's the episode of care. And you just keep hearing the same thing when we talk about these quality measures. They're all very much aligned that way. The measure is calculating using data from the OASIS, as you are aware of. This measure replaces the current pressure ulcer measure, percent of residents or patients with pressure ulcers that are new or worsened, short stay, and you can see the NQF measure that's there. This is a cross-setting quality measure implemented to meet the requirements of the Improving Medicare Post-Acute Care Transformation Impact Act. Now, as I'm going to go through today, there's been a fair amount of questions that are repeated every time we do some of this education. So this is that second bullet's an important bullet, because some of the answers that I'm going to give you, you're going to be like, well, Ann, why can't I assess the skin for the full 5 days during an assessment period? And I'm going to reiterate as I go through in the training that we are trying to align these measures across the 4 post-acute settings, and we saw some slides there, right? Inpatient rehab facilities, long-term care acute hospitals, skilled nursing facilities, and then, of course, home health. The other 3 settings have what in common? Bricks and mortar, right? So they're living and everyone is treating in this one environment. So home health is unique that you're treating in the home. And so, but we are trying to, and we are trying to align these measures. So when I say the first or initial skin assessment, it's that same definition that we need to use in those same other settings. And that's the reason it's so important that we don't just take that 5 days to assess them. That the first time that we can get in there and assess the skin, that's the initial skin assessment. So I just wanted to, and I will reiterate that, but I think that's an important piece in understanding the rationale behind some of the decisions that have been made. So updates, the modified version includes newer worsened unstageable pressure ulcers or injuries, including deep tissue injuries, in the measure numerator. So that's new. The measure calculation has been amended to include M1311 instead of M1313, and these were to reduce redundancies. And these revisions are informed by the National Pressure Ulcer Advisory Panel guidelines. So they're not exactly from them, but they are informed by them. So this is what I was talking about just a moment ago. The quality measure has been uniformly adopted across the post-acute or PAC continuum. So in each one of these settings, we've been implementing these same quality measures: long-term care, acute hospitals in July of 18, skilled nursing in October of 18, inpatient rehab facilities we did in October of 18, and then for your home health, we did this in January of 2019. So this is newer for you. But the importance is this is a shared measure or an equal measure across all of these settings. So let's look at the definition, because I think it's really important to understand what feeds a measure. Because if you're looking to use the data to drive quality, which we hope you are, you need to clearly understand what gets put in the numerator and what is the denominator, and what are the exclusions, and we're going to go through that. The numerator, to be included in the numerator, the number of completed quality episodes for patients whose assessment at discharge indicates one or more new or worsened stage 2 to 4 or unstageable pressure ulcers or injuries, compared to the start or resumption of care. And we're actually going to go through these. We're going to look at the definitions, and we're going to talk about the idiosyncrasies in doing that, and how these are triggered, and get into the numerator. And then the denominator includes the number of quality episodes, except for those that meet the exclusion criteria, which is the next slide we'll go through in a moment. And home health quality episodes are defined by pairing the assessments completed at the start or resumption of care with a assessment completed at discharge, and we talked about that earlier. So the exclusions, who's going to be taken out of this measure? Well, episodes that end in a death at home or transfer to the inpatient facility are excluded from this measure as an OASIS data collection that occurs at these time points and does not contain the items needed to compare these measures. So if your discharge is due to death, this measure will be excluded, okay? That episode will not be included in your numerator. Or if they're transferred to an inpatient facility, it will be taken out. Also, we have episodes without an assessment completed at the start or resumption of care and an assessment completed at discharge. So if we don't have the front and the back end, the comparison, those cases will be excluded. And then we always have this third exclusion, which will be if there's missing data. For some reason, if there's missing data, then we can't calculate this particular measure. So these are the exclusions. Probably the top one is the most important for you to be aware of. The measure will be calculated quarterly, so it's a quarterly calculated measure, using a rolling 12 months of data. So as one quarter ages out and a new quarter comes on, so you're kind of constantly getting a 12-month snapshot of time. For public reporting, the quality measure score reported for each quarter is calculated using that rolling 12 months of data. So as it's reported, like I said, a quarter will fall off and a new quarter will come on. All completed quality episodes during the 12 months, except those that meet the exclusion criteria, are included in the denominator and are eligible for inclusion in the numerator. So if we have that sock rock and we have the discharge that doesn't meet the exclusion, they are eligible. For patients with multiple episodes during a 12-month time window, each of those episodes is eligible for inclusion in the measure. So if for some reason you had a start of care and a discharge, let's say in January into February, and then for some reason, so you discharge them off of service, and then they come back in 2 months later and they have another episode. So potentially someone could have 3 or 4 episodes. As long as they had the start of care, resumption of care, and a discharge together, that completes 1 episode. So you potentially could have one patient having 3 or 4 episodes. This measure will be risk adjusted based on an evaluation of potential risk factors and their statistically significant impact on the outcome. So what we mean, let's look at these, but what we mean by risk factors, it is just that. Those things that potentially could put someone at a higher risk for developing skin issues. So if we look at these, we have functional mobility. So this is this item, GG, 0170C, mobility, that particular question of lying to sitting on the side of the bed, is a risk adjuster. So if someone has more difficulty in doing that, makes sense, right? It's probably a functional mobility issue. So they are at higher risk. Bowel incontinence on the sock rock, M1311, at least occasional bowel incontinence, puts someone at higher risk. And that makes sense if you're a clinician. If the person in M1311 is checked off as having peripheral vascular disease, peripheral arterial disease, or diabetes, it makes sense. They're at higher risk. And then the last risk factor here is the low body mass index, which is calculated using height and weight. So that's M1060A. and M1060B, so giving you your BMI. And again, if you look, it's putting you at risk for low body mass index, not high. So it's important to understand these are risk factors. So we always should be careful when we're answering all of our questions on any of the assessment tools in the OASIS, but know that these are factors that are driving the risk score. So if you had someone who was up and about, who didn't have any issues with mobility, who was totally continent of their bowels, didn't have PAD or peripheral vascular disease or diabetes, and was of normal weight, they would be rated with less risk of developing a skin issue. So that's how the risk adjustment goes. All right, so M1311, the current number of unhealed pressure ulcers or injuries at each stage. So what we're looking for here is this item identifies the number of pressure ulcers or injuries at each stage, so stage 2, 3, or 4, and or designated as unstageable that are observed on the assessment. At discharge, this item also identifies each pressure ulcer or injury present on the discharge assessment was observed at the stage at the time of the most recent sock rock. So what we're saying, and we're going to go through this, is at discharge, it asks you how many of these things do we have? How many stage 2s, how many stage 3s, how many stage 4s, and then it goes through the unstageables due to non-removable dressing, eschar and slough, and so we'll go through those questions. And then it will ask you, of these that you have here at discharge, how many of them were present upon admission? And we're going to go through that in detail. Now, a stage 1 pressure injury and all healed pressure ulcers or injuries are not reported on this item. And I think we have some samples around that. So what are the time points? Well, we talked about this already, the start of care, resumption of care, follow-up, and then discharge from agency, not to inpatient facility, and or I would add in there death, right, because that's an exclusion from this. So the general revisions that we have here, the items retained but different versions created for specific time points. The language is modified to align with other PAC instruments. These are adapted from the National Pressure Ulcer Advisory Panel definitions and terminologies. And there's a modified skip pattern language and directions. And we're going to go through that when we start doing some of the coding scenarios. Other text revisions that you'll see, and we've kind of talked about already in past trainings, we added ulcer/injury where applicable. We added the word device to the item title in D1, and it says really unstageable, non-removable dressing is what it used to say, but now it says non-removable dressing / device. And then remove suspected in the evolution of F1 unstageable deep tissue. It used to be suspected deep tissue injury, and now it's a deep tissue injury. So just, again, clarifying language here. The dash. So the dash is a valid response for this item at discharge time points only. But CMS expects dashes to be used on a rare occasion. So if for some reason you had to dash on the discharge, you could. But the expectation is that you'll be able to code this item. So CMS doesn't expect to see this showing up a lot. So here is a screenshot of M1311, the current number of unhealed pressure ulcers or injuries at each stage. And here we're looking at the SOC-ROC and follow-up version. And what you'll see throughout this screen here is some highlights in yellow. And these are some of the things that I just went through as far as terminology change. So M1311 now says current number of unhealed pressure ulcers / injuries at each stage. And then you'll notice as you go through items, when we start getting into D1, it says unstageable, non-removable dressing / devices. So you may have a device that has an order that you can't remove it, and you know there's a pressure ulcer under it, but you can't stage it because you can't remove that device. We used to just have it as dressing, and now CMS has added device. So you'll see where we also then, we go on to talk about ulcers and injuries. And then in F1, you see unstageable with the term deep tissue injury, so that word suspected is gone. And then the number of unstageable pressure injuries presenting as deep tissue injuries. So you'll see that the terminology has changed there. As you go through here, this is the discharge version. And so you'll notice that, let me just go back. So here is, we're going to do it the SOC and the ROC, and this is just saying, what are we seeing on this initial assessment? What do we have? And you're encoding those. Now, when you look at this next screenshot here, this is done at discharge, and what it's doing here is comparing one to the other. So here again, you will say, in this first question here, stage 2, partial thickness loss of dermis presenting as a shallow open ulcer with a red or pink wound bed without slough, and may also present as an intact or open or ruptured blister. So it's giving you kind of the definition. What is a stage 2? So you don't have to go back and refer anywhere else. And then it's saying here, you would say in the first question is, what do I have now at discharge? Okay, so what do I have today at discharge? And then if I said I have 0, I don't have any of these, so let's assume that I put a 0 in there. Then the follow-up question is the number of these stage 2 pressure ulcers that were present at the most recent SOC or ROC. So let's think about this calculation here. If I have 0 for stage 2, the next question is, of those 0 pressure ulcers of stage 2, how many were present on the SOC and ROC? What would you say? 0, right? Actually, it's a skip. And if you have a computer program, it will just skip out because the technology has that. So if you have 0, then you can't have any of those present upon admission, right? So it will always be a skip kind of pattern for that second question. If the first question is at discharge, you don't have any of those. All right? Okay. And we're going to go through some of the other examples. And then here is just, again, highlighting some of the changes. But here we're looking at the unstageable for non-removable dressing or device. And then we have the unstageable slough and eschar, and then unstageable deep tissue injury. And again, you're being asked the same thing. What do I have on discharge? And of those, what were present upon admission or start of care? So let's go through and work on some of these. So what we want to look at here is determining present at the most recent SOC or ROC. For each pressure ulcer injury observed and coded at M1311A1 through F1 on the discharge, determine whether that pressure ulcer injury was observed at the same stage at the time of the most recent sock rock and did not form during the home health quality episode. So we need to understand what was there at the start or resumption of care and then what we have at discharge, and then we're comparing those. So here we have a continuing looking at determining present at the most recent sock rock. So if the pressure ulcer injury was unstageable at the sock rock, but becomes numerically stageable later, when completing the discharge assessment, its present at the most recent sock rock stage should be considered the stage at which it first becomes numerically stageable. So that was a mouthful. What does that mean? So if something is unstageable at the sock rock, we're going to code it as that, right? Unstageable due to slough or eschar, or non-removable dressing, or deep tissue injury, right? Those are the three choices. So now, I do those, my initial skin assessment. So maybe 2 weeks into care, we now either the slough or the eschar is removed, or the device or the dressing is removed, or if it was a deep tissue injury, it's what we call it declared itself. Now we're able to stage it. So let's say now we stage it as a stage 3. That then becomes, when we go to do the discharge, that now becomes present upon admission. Does that make sense? So even at the sock rock, we said, well, we're not sure what's under there. We know there's something, but we're not sure what it is. As soon as we can numerically stage it, we can now say that that was present upon admission. That's an important piece of this. Everyone got that? I'm seeing some nodding. Okay, sorry. All right. If the subsequent increase in numerical stage, do not report the higher stage ulcer as being present on the most recent sock rock when completing the discharge assessment. So what the second part is saying, okay, so now let's go through that same scenario. I had either a dressing or eschar or a deep tissue injury. 2 weeks later, I stage it as a 3. And now 4 weeks later, after that, it's a stage 4. It's just progressed. Now it's a stage 4. That stage 4 is not considered present upon admission because it got worse. All right, any questions on that? Everyone got that? Okay. So the general standard of practice for patients starting or resuming care is that the patient assessments are completed as close to the actual time of the sock rock as possible. If a pressure ulcer injury that is identified on the sock date increases in numerical stage within the assessment time frame, the stage of the pressure ulcer injury at the first skin assessment completed would be reported at M1311 1 at the sock. So here is probably where the majority of the questions that we have received over the trainings that we've done. And the questions are saying, well, wait a minute, what if I had a non-removable dressing? I went in, we got the referral, I went in within 24 hours. I went in and I assessed the patient and I had an order that couldn't be removed for whatever the dressing was, let's say 3 days from now. So I go back in 3 days and I've done my initial skin assessment, so I have that non-removable dressing. I go in 3 days later and now I can take that dressing off and I'm like, oh, you know, what we have is a stage 3 under here. People are saying, well, why can't I just code that as a stage 3, right? Because I have a 5-day assessment window. That is probably singularly one of the biggest questions, the most difficulty that home health has had. And the idea here is going back to what I said earlier in the day, or earlier in my session, which said we are aligning measures across all those post-acute settings. And in the post-acute setting, if you're in a brick and mortar, within hours of someone being admitted into your organization, you've done a skin assessment. Now, it's unrealistic that as soon as the person gets home, you may or may not have a nurse right in there, but usually within 24 to 48 hours, or clinician getting in there, you're going to do that initial skin assessment. So whatever you see on that skin assessment initially is what goes on the sock rock. So I think it's a good teaching point for you to bring back to your organization. As I was reviewing Q&As from past trainings, that concept was written in probably 30 different ways with different scenarios, but it's the same concept. Why can't I, and then it doesn't matter what it is, within that 5-day period of time. So I need, I think as a teaching point, both for everyone that's here and online, but going back to your agency staff, it's that initial skin assessment, and that's what aligns with all of the other post-acute settings. All right. So here we have M1311 A1 through F1, and at Sock Rock and follow-up, you enter the number of ulcers for each stage that are observed at the first skin assessment completed during the assessment time frame. Everything we've just talked about. So at the Sock Rock in B1, enter the number of stage 3 pressure ulcers that are observed at the first skin assessment completed during your Sock assessment time frame. Enter 0 if no stage 3 pressure ulcers are observed. So if we look at our screenshot here, so if this is the assessment, under B1, which is our second line there, if we had 1 stage 3 pressure ulcer, we would enter in the numbers column 1. We have 1 stage 3 pressure ulcer that we found on our initial assessment. And then, assuming there's nothing else that we found, we would just put zeros in the rest of the assessment. At the discharge assessment, we enter a response for each row of the items. So that's A1, and then there's A2, and there's B1 and B2. And we'll look at a screenshot. So at discharge in A1, enter the number of stage 2 pressure ulcers that are observed at the discharge assessment. If no stage 2 pressure ulcers are observed, enter 0 in A1 and skip A2, and we kind of talked about that already. If at least 1 stage 2 pressure ulcer is observed, so this is at discharge again, if we observe that stage 2 and report it in A1, enter in A2 the number of these stage 2 pressure ulcers that were observed at the same stage at the most recent Sock Rock. So let's look at this from a coding perspective. So if we say, this is the top question over here, if we say stage 2 pressure ulcers at discharge, so again, remember, the first question is asking, what do I have at discharge? That's very important. So if I enter 0 in that first box, then A2 says, of these ulcers that were present on the most recent, how many of these ulcers were present at Sock Rock? Well, I don't have any at discharge, so again, that would be a skip. Now let's take it if I had 1. If I have 1 stage 2 at discharge, then it's going to say to me, A2 question is saying, all right, so you have a stage 2 pressure ulcer. Was that ulcer a stage 2 at admission or your first skin assessment, Sock or your Rock? And if so, you would have 1 for the first one, A1, and then 1 for the second one. But let's say you said, all right, I have 1 on discharge. I'm giving you 3 different scenarios here, right? I had a 1 on discharge, so I have 1 stage 2. And then when I go back and I say, of these stage 2s, how many were at my Sock Rock? And I go back to my Sock Rock and I'm like, oh, I didn't have any stage 2 pressure ulcers. Well, now I need to say 0. So none of these ones that we have at discharge were present on the Sock Rock. So that really would be considered new or worsened, okay, because we didn't have it. And these just go through the other questions. So this is just unstageable. So just so you can get a clear that these items together, it's hard to put on one screenshot, but they go together. So let's look at some additional coding guidance. So let's go through the pressure ulcer definitions. So CMS adheres to the following guidelines, so these are important. A stage 2 pressure ulcers are characterized by partial thickness loss of dermis, presenting as a shallow open ulcer and a red-pink wound bed. And what is the biggest caveat? Without slough. If you have slough, can it be a stage 2? No. Okay, good. Singularly, probably one of the most important training points for your staff. I think that is, when you look around and people will describe, they'll say it's a stage 2 because it's superficial, and then they describe this yellow slough. If you have yellow slough, it cannot be a stage 2. It also can present as an intact or open or ruptured blister. And then we have the stage 3s. It's a pressure ulcer, are characterized by full thickness tissue loss. Subcutaneous fat may be visible, but bone, tendon, or muscles are not exposed. Slough may be present, but does not obscure the depth of the tissue loss, so may include undermining or tunneling. So you need to be able to understand that even if it's completely covered, you certainly can assess it, but if it's partially covered by slough and eschar, and you can see and assess the wound, then you can go ahead and be able to code it. A stage 4 pressure ulcer are characterized by full thickness tissue loss with exposed bone, tendon, or muscle, and you may have slough and eschar over some or part of the wound bed, but it often includes undermining and tunneling. So if you're looking at a wound, and it can be 50%, 60% covered with eschar, and you see bone or you see tendon, what do you have? You have a stage 4, right? I mean, you can see those anatomical things that are not included in any of the other stages. The other things to remember is that a previously closed stage 3 pressure ulcer, and it currently opens again, should be reported as a stage 3. So if you could say that ulcer was a stage 3, closed, and we're going to define closed in just a moment. So it closes and then reopens over the exact same spot, that exact same ulcer, it is considered a stage 3. Even though it might present as something else, it was a stage 3. And the same thing for a stage 4. All right, we go through then to make sure that what do we consider healed versus unhealed. And what we're looking for here is whether it's closed versus opened. And the thing to remember is that we don't reverse stage. So that's an important point. So we don't backstage, we don't reverse stage. So pressure ulcers do not heal in a reverse sequence. And in fact, the body does not replace the types or layers of tissues, so the muscle, fat, and dermis that were lost during the pressure ulcer development before reepithelialization. So in fact, if a wound, they say on average that if you have a closed, healed wound, that the tensile strength of that skin and the underlying tissue is about 80%. We're born with 100%, right? So it's never going to be as strong as a part of your skin that's not had an injury. So let's go back here. So stage 1 pressure ulcers or injuries and deep tissue injuries, although closed, meaning they have intact skin, would not be considered healed. So if you have a deep tissue injury, right, that deep maroon, red kind of coloring, and the skin is intact, it's not considered a closed injury. It is still considered a deep tissue injury. It's not considered healed. And then an unstageable pressure ulcer or injury, whether covered with a non-removable dressing or eschar or slough, would not be considered healed either. So the clinician should make every effort to contact previous providers, including the patient's physician, to determine the highest numerical stage of pressure ulcer. So you want to look at transfer paperwork. If there's any question, you can call back to the previous level of care and try to find out what was the stage of a particular injury. So have you ever had someone who's come out of a care setting who maybe spent a couple of weeks in the acute care, maybe went to a SNF, an IRF, or an LTAC for a period of time, and now you're getting them as a home care patient, right? So they might have been 5 weeks into or 6 weeks into an episode by the time you get them, like multiple settings. And what you're seeing may be, in fact, a healing stage 3 or a healing stage 4. So you want to try to say, if you can find out whatever the deepest anatomical stage of that pressure ulcer is, and that's what you're going to code it as. Does that make sense? So it's really important to try to make sure that you find the documentation or talk to someone to figure out what was the deepest anatomical stage. Because often it will look different for you if they've had care in other settings. And that's important. Why? Because we don't reverse stage, right? So it's just a healing. So a healing stage 4 pressure ulcer, you wouldn't want to say, oh, it looks like we have a stage 3, that's what I'm seeing, and in fact it was a healing stage 4, because it could deteriorate, right? And now you're able to code it as a healing stage 4. The stage 4 was its deepest anatomical stage. So even if you're observing it to be a 3, but you're saying it's a healing stage 4, if for some reason there's some more skin breakdown, okay, because it's a healing process, that it wouldn't be considered worsening. So unstageable pressure ulcers that have eschar, and we know eschar to be that tan, black, brown, leathery kind of look to it, or slough, that yellow, tan, gray, green, sticky materials. The tissue presents such as the anatomical depth or soft tissue damage cannot be visualized in the wound bed, should be classified as unstageable. So if that wound's completely covered, we don't know what's underneath it, we need to say it's unstageable due to slough and eschar. If the wound bed is only partially covered by the eschar or slough and the anatomical depth of the tissue damage can be visualized, so that example in the stage 4 where I'm looking at it and I can see bone, okay, we know it's a stage 4. Then you want to numerically stage it and do not code it as unstageable. So if it's very clear what you're dealing with, then you can go ahead and code it. So at discharge, any numerically stageable pressure ulcer injury observed at sock rock that is unstageable due to slough and or eschar at discharge should be considered new and not coded as present at the most recent sock rock. So for example, if you have a stage 3 ulcer at the sock rock, and then at discharge that same ulcer is now unstageable due to slough and eschar, you would code it as, at discharge, as unstageable due to slough or eschar, not present upon admission. Okay, we're going to go through some of these examples. So let's talk about the non-removable dressings and devices. So pressure ulcers are injuries that are known to be present but are unstageable due to non-removable dressings or devices should be reported on M1311 D1 unstageable. So there's a couple of key points here. So if you have a cast or you have some sort of a dressing that you have in order you can't remove, you need to know that there's an ulcer underneath it to code this, right? So there should be some sort of communication or documentation that they had some sort of a pressure ulcer or injury under that, and you just can't observe it with your eyes because you can't remove that dressing at that time. You want to report that as saying, we know there's something under there, but I haven't looked at it to be able to say exactly what it is. Okay. And it could be any number of these things: negative pressure, wound therapy, it could be an orthopedic device, it could be a cast, it could be a primary surgical dressing, it could be any number of things that we see underneath that. Known refers to when documentation is available that states the pressure ulcer or injury exists under the non-removable dressing or device. Now, that could be in documentation, so it could be a transfer document, it could be notes, progress notes that are sent to you, or it could be obtained from a verbal report from a previous setting. So that can be counted also, where you talk to someone, you had a warm handoff, and they explained to you that they had this particular ulcer underneath or injury underneath the dressing. So on the discharge assessment, if an unknown pressure ulcer or injury is discovered upon removing of a non-removable dressing or device, that pressure ulcer injury should be considered new and not be coded at present upon the sock rock. So what are we saying here? In this situation, we looked through the paperwork, we talked to maybe the previous setting. No one said anything about an injury underneath that dressing device or whatever. Now we get an order, we can remove it. We remove it and we're like, oh, we have this injury underneath there. Okay, well now it should be considered new and not present upon admission because it was unknown that we had it underneath it. So a purple or maroon localized area of discoloration, intact skin or blood-filled blister due to damage of underlying soft tissue from pressure ulcer or shear is the definition for deep tissue injury. And a deep tissue injury with intact skin at the sock rock that becomes stageable is considered present at the most recent sock rock at the stage at which it first becomes numerically stageable. So that's that same definition that we've talked about already. So it's unstageable due to a deep tissue injury as soon as, and usually with deep tissue injuries we call it declaring itself. It evolves into whatever it's going to be, and then the skin gets open and whatnot. At that point, when you can first stage it, that then becomes present upon admission. These are subtle points but important points, all right? Because you know you have an injury there. You just don't know what it is. And the same thing would be if it was completely covered with slough or eschar. We know that there's an injury. We just don't know what stage it is until that's either chemically or physically debrided. So surgical interventions, any type of flap procedure performed to surgically replace a pressure ulcer is reported as a surgical wound until healed. It should not be reported as a pressure ulcer or injury on M1311. So if we had a pressure ulcer, and they usually do a flap or surgical procedure to replace it, that wound that was previously a pressure ulcer now is considered a surgical wound and not coded at M1311. A pressure ulcer treatment with any type of graft is no longer reported as a pressure ulcer or injury, and until healed should be reported as a surgical wound. So here we have a graft applied. Same thing, same equivalent as having a flap. It would not be considered a pressure ulcer or injury. It's now considered a surgical wound. But a pressure ulcer that has been surgically debrided, which is a different scenario, remains a pressure ulcer and should not be reported as a surgical wound. So these are subtle differences. So the flap or the graft now makes that wound a surgical wound. Surgical debridement, chemical debridement, whatever, is not, it continues to be a pressure ulcer or injury and would be coded as in the pressure ulcer area, M1311. So here's another caveat, mucosal ulcers. So mucosal pressure ulcers are not staged using the skin pressure ulcer/injury staging system because the anatomical tissue comparisons cannot be made. So therefore, mucosal ulcers, those related to NG tubes, oxygen tubing, endotracheal tubes, urinary catheters, mucosal areas in the oral cavity should not be coded on the OASIS. Okay? So that's an important piece of this. Just think about it. The anatomy is different, right, in the mucosal area. Let's see, pressure ulcers occurring to mucosal membranes would be reported in the comprehensive assessment and clinical documentation, but not in any of the following OASIS-M items: M1306, M1311, M1322, or M1324. So it would not be coded in those particular areas. So again, I think this is a training opportunity when you work with your staff. All right, so we're going to go through some practice scenarios. Now these are going to be, get your phones out, because these are Slido. So this should pull some of this together, and then again, after lunch, we will also do some scenarios. So here's the first scenario. A patient is admitted to home health with a stage 3 pressure ulcer on her coccyx and has no other pressure ulcers are present. At discharge, it is entirely covered, the same wound is entirely covered with eschar, and the wound bed cannot be assessed. No additional pressure ulcers arise during this episode. So so we have admitted with a stage 3, discharge with slough and eschar completely covering that same wound, all right? The patient is discharged from the home health services with an unstageable pressure ulcer due to slough and eschar. So now let's go through and let's code this. So how would you code M1311 on the sock rock assessment? would it be A, 1311A1 stage 2, M1311B1 stage 3, M1311C1 stage 4, or M1311E1 unstageable slough or eschar? Okay, we're getting there. We have about 50 people who have responded. So again, this is the start of care assessment. Start of care assessment. All right. All right, so let's take a look and see what we have here. So the answer is B, stage 3. So the caveat here was you needed to know we were asking about the start of care, right? They were admitted with a stage 3 on their initial skin assessment. All right, so now I saw some of people put unstageable, and I think they were thinking the discharge assessment. So I'm sure that's where that confusion was. So here we have another question. How would you code M1311 on the discharge assessment? So again, discharge assessment, that same wound. So would you code it as 1311A1 stage 2, being one of those, 1311B1 stage 3 as one, M1311C1 stage 4, or 1311E1 unstageable due to slough and or eschar? So now you're coding at the discharge assessment. Okay, so the majority of people, almost 96%, said that we have an unstageable to slough or eschar, and let's look at the answer. So in fact, you are correct, unstageable due to slough or eschar. So now let's ask the next question. So you did a great job here. So the next question is, was this unstageable pressure ulcer due to slough or eschar present at the start of care? Right, that's that second question that we're asking. So in this scenario, would we say yes or no or skip? I'll just give it a moment so we get a few more people getting there. Okay. So we have about 8% saying, 9% saying yes, and 92% saying no. So let's move on and let's see what the answer is. There we go, sorry. Was this unstageable pressure ulcer due to slough and or eschar present at start of care? And the answer is no. Now there was some confusion. So we know, let's just go through this. We know at the start of care we had a stage 3. And then we knew at discharge we had, in that same ulcer, has slough and eschar. So on discharge we're saying, hey, we have one with slough and eschar, right? And was the unstageable pressure ulcer due to slough or eschar, was that same ulcer present on admission? And we're saying no. And why? Because with the new, when we're looking at this new quality, the presence of slough or eschar in a previously staged ulcer is considered new or worsened. Okay, so if we look at this scenario here, this is the practice scenario. If we were going to look at this kind of on our assessment, number of stage 2 pressure ulcers, this is going off the previous assessment that we just did. We would code 0, 0, so we didn't have any stage 2s on discharge or on start of care. And then, of course, it's a skip pattern because we had 0 at discharge. The next one is the stage 3 pressure ulcers. We're saying, well, we had 1, right, at the start of care, and we didn't have any at discharge. And then it asks us, of these stage 3s present at discharge, again, we have 0, so it's an automatic skip. And then we don't have any stage 4s, and so we'd skip out of this. And then here we go into the unstageables. So we didn't have any non-removable dressing, so 0, 0 and a skip. Now we're getting into the E1, which is the number of unstageable pressure ulcers due to slough and or eschar. We didn't have any of those at the start of care, right? We had 0, but we now have 1 at discharge. And so the number of these unstageable pressure ulcers that were present at the most recent stock or rock, it's now going to be 0. We didn't have any of these. So this just gives you, again, more for training opportunities when you go back to your organizations and do it. And so we already kind of went through this. We talked about B1 would be coded as 1 on the sock rock. And then at discharge, we went through this, that we have the slough and the eschar. So this gives you your rationale. Now, the ones that are posted online don't have all the answers to them. Just a reminder, after the trainings, we do post everything with the answers. So you have it all when you go back to your organizations. And you can use these scenarios or use your own scenarios. It's always best if you can use your own scenarios in your organization to be able to allow staff to practice these. And you can determine competency also. So let's go scenario 2, and we'll speed this up a little bit. So a patient is admitted to the home health with referral documentation indicating the presence of a stage 3 sacral pressure ulcer. This ulcer is covered with a non-removable dressing and therefore is unstageable at SOC. No other pressure ulcers or injuries are present. An order is obtained to change the dressing on day 4 of the quality episode, and the assessment reveals a stage 3 pressure ulcer. On day 9 of the quality episode, the pressure ulcer is covered with eschar and is assessed to be unstageable. The eschar-covered ulcer is unchanged at the time of discharge, and no other pressure ulcer injuries developed during the quality episode. So there's a couple of things happening. The initial assessment says, we know there's an ulcer, and but it's covered with a non-removable dressing or device, right? Then at day 4, when we can take the dressing off, the ulcer reveals a stage 3 pressure ulcer. So that's the first time, right, that we can stage it. And then the last part of this says on day 9, it goes to unstageable, and at discharge, it's unstageable due to slough and eschar. All right, that's the scenario. So let's go through and quickly answer. And this, again, a Slido. How would you code M1311 at the SOC? Do we have any, at B1, any stage 3s? Would we code it as a 1? Unstageable non-removable dressing, would we code it as a 1? Unstageable slough or eschar as a 1? Or unstageable deep tissue injury? Okay, so we have about 16% of the people saying it's a stage 3. We have 80% saying it is unstageable, non-removable dressing. And we have unstageable due to slough or eschar. We have about 4%. We have about 13% now on stage 3. And I am going to, let's look at the answer. So how would you code M1311 here? It is, in fact, unstageable, non-removable dressing. Some people got confused with that stage 3, right? So this is, again, a teaching moment, and this is where I think there's some confusion. The initial skin assessment, even though it was in that 5-day period, the initial one says we know there's an ulcer underneath it, we just can't see it because there's this non-removable dressing or device. So in fact, that is what you're going to put as a sock rock. Now, the information that you gathered 4 days later when you remove that dressing and it's a stage 3, that's important to know because when you go to discharge, that stage 3, if it had stayed a stage 3, you would have said it was stage 3 present upon admission. I know I had a stage 3, okay? Because you can say that because the first time that you can numerically stage it, because you knew you had something there, that becomes the start of care stage of the ulcer. All right. Now let's look at how would you code this same scenario at discharge. Would you say you have a stage 3 as a 1, unstageable, non-removable dressing as a 1, unstageable due to slough or eschar, or a unstageable due to deep tissue injury? Okay. So let's see what we have the answers. We have 2% saying stage 1, 3% saying, well, it's down to 1%, so let's just go to the C is the most popular answer, unstageable due to slough or eschar. And in fact, let's look at our answer. and it is unstageable due to slough or eschar. And that is because at discharge, that wound is covered with slough or eschar, okay? And that was not present upon admission. Okay. So was this unstageable pressure ulcer due to slough or eschar present upon the start of care? So would you say yes, no, or skip? Exactly. So we still have about 15% saying yes. So there's still some confusion. I'm trying to think of how else to say this so that, because this is an important point. You had, again, it was, your start of care would say you had a non-removable dressing. Day 4, you were able to stage it as a stage 3, so that's the first numerical stage. So that now continues for the rest of your assessment. At discharge, if that had been coded as a 3 at discharge, then it would have been considered present upon admission. But now, since we don't have it as that, we have this new thing with slough and eschar. We have the same wound, but now it's slough and eschar. That's considered not present upon admission. I hate to pound this, but this is a point that people are getting stuck on. Okay, let's see the answer. I already gave it to you. It would be coded no, because it wasn't present. And then I'm not going to go read through these, but this would be exactly how it would be coded if you were looking at your OASIS, all right? So here, all of these would be zeros, okay? And then we have the unstageable due to non-removable dressing at admission, and then we have unstageable due to slough and eschar at discharge, and we didn't have any of those present upon admission. So what you'll notice on this, let me go back one thing, is do you see the stage 3 there coded at all? No? Right, and that's the correct way to code this. Why? Because this SOC assessment, or start of care assessment, said we had a non-removable dressing, right? We didn't see a stage 3 on that initial assessment. And then it was only when we moved forward and we looked at the discharge assessment, we said, well, now at discharge, do we have any stage 3s? Nope, we don't have any. So we're going to skip out of that. We're not going to say how many were present upon admission, but we now have a wound that is unstageable due to slough and eschar. And we're going to say we have one of those and none of those present upon admission. That's kind of the rationale to think that through. All right, and here's the rationale statement. I'm not going to read this to you because this is everything that we just talked about. And all right, very quickly, we've only got a couple minutes left, and then I'm between you and lunch. This is the last scenario. So the RN completes a skin assessment during the SOC visit for Mrs. K and identifies a right hip DTI with intact skin. This DTI is first numerically stageable at 10 days later as a stage 3 pressure ulcer and increases in numerical stage 5 days after that to a stage 4. The pressure ulcer remains at a stage 4 at discharge. So DTI on the first assessment, day 10, it's a stage 3. Day 14, it's a stage 4. And on discharge, it's a stage 4. So those are the scenario that we have. So let's look at this. So how would we code this? How would you code the SOC assessment? Would you have a stage 3 as a 1, stage 4 as a 1, unstageable slough or eschar, or unstageable DTI? And okay, so let's see what the answer is here. The majority of people, actually everyone, says it's a DTI. And that is exactly it, unstageable DTI. All right, so now let's look at the discharge assessment. So how would you code M1311 on discharge? Would you code it as a stage 3-1, a stage 4-1, unstageable slough or eschar, or unstageable DTI? Again, this is the discharge. What are you seeing on discharge for this patient? Okay, we have a good number of people responding. So let's look at the answer. And in fact, it's a stage 4. So some people said, oh, it's unstageable DTI. Well, again, remember, we're looking at the discharge. What are we seeing today at discharge? And what we saw today is we had a stage 4 pressure ulcer, right? Now the next question is, was this pressure ulcer present at the start of care? Yes, no, or skip? Okay, just give it a moment. And we have 17% saying yes and 82% saying no, and a couple want to skip it. Okay, let's look at the answer. And actually, no. So it was not present on the start of care. Why? Very quickly, and I'll go through the rationale. Here's how you would code this. So on admission, we had a deep tissue injury. So for start of care, we didn't have any of those. But we notice on discharge, we have one stage 4 pressure ulcer. And then what you'll see here is on the start of care, we have the deep tissue injury coded, but no deep tissue injury on discharge. So the issue here is people will say, well, wait a minute, you didn't code the stage 3. Well, we're looking at 2 points in time, the initial skin assessment and discharge. So in that situation, that stage 3, okay, we know that that was the first numerical stage, and then it got worse. So if it had stayed at stage 3, it would have been present upon admission, and it would have been present on discharge. Does that make sense? Okay, it's because it got worse. And then here's the rationale around that. The stage 3 ulcer increased to a stage 4, therefore the stage 4 pressure ulcer at discharge is considered new or worsened. And then this talks about the discharge assessment here. And so M1311C2 is coded as 0 because the stage 4 pressure ulcer was not present upon the rock. All right. I see Bridget running up. So she's going to give some instructions. When we come back, though, we're going to start with an activity. I'll start you off with an activity where you can now process through. We're going to give you scenarios, and you're going to code independently. And then I'm going to review the answers to those. So, Bridget. All right, so we have a half an hour to finish up this section. What I want to do is take the next 10 minutes. And if you all could pull out your coding scenarios for day 1, and those of you that are online, if you could do the same thing. And if you pull out those packets, and hopefully you've downloaded those from the website, I want you to take about 10 minutes to complete scenarios 4 through 7 using your coding guide. So it gives you the scenario. And then if you go through and independently work through how, if you were doing this OASIS based on the information given, how would you code scenarios 4 through 7? So we'll give everyone about 10 minutes to do that. I'll actually set my timer. Then we'll come back and then we're going to go through those scenarios and we'll go through how it actually should be coded and we'll go through the rationale. So this actually will hopefully have you have a good understanding and feeling comfortable in completing these scenarios. And again, I would think about from your action plan as you're moving forward that you want to probably think about these scenarios and how else can you use these scenarios or your own scenarios, but the same type of strategy to actually use for competency with your staff and those kind of finer points that we talked about, those idiosyncrasies and those difficult areas that can be confusing to people to code. So I'm going to give you 10 minutes to start your coding, starting now. Okay, I think we'll get started so that we can have enough time to go through these coding activities. Everyone pretty much done in the room? I'm seeing some continuing to work, some done. We have about 20 minutes left, so to stay on time, let's go ahead and look at this coding activity. So scenario 4, the RN assesses Mrs. L's skin during the assessment time frame for the start of care and identifies a deep tissue injury with intact skin on her right heel. This DTI first becomes numerically stageable at the 3rd home visit as a stage 3 pressure ulcer. At the discharge skin assessment, this pressure ulcer is unstageable due to slough or eschar. So let's look at how we would code this. So here we have the start of care and then the discharge assessment. So the first question is 1311A1, number of stage 2 pressure ulcers at the start of care. Do we have any stage 2 pressure ulcers at the start of care? No, so we'd have a 0. Okay, so the second question here, and we're going to look at the discharge assessment. So number of stage 2 pressure ulcers on the discharge assessment. 0, right? Good. And then the number of these stage 2 pressure ulcers that were present on the most recent sock rock. So what am I hearing? 0, or, well, really it should be skip, right? So this would be a skip pattern because we don't have, remember we talked earlier, if we have 0, it would be a skip. Okay. So then the next question is number of stage 3 pressure ulcers on the start of care. Do we have any stage 3s on the start of care? No, 0. Okay, correct. How about on discharge? Do we have any stage 3 pressure ulcers on discharge? Correct, 0. We don't have any on discharge. All right, how about the number of these stage 3 pressure ulcers that were present at the most recent sock rock? Skip, really, is what it would be, right? So you don't have any. Okay, the number of stage 4 pressure ulcers. Do we have any stage 4s on the start of care? No. How about on discharge? Right, we didn't. We had 0 on discharge. Someone had the right answer for the next question. The number of these stage 4 pressure ulcers that were present on the most recent sock rock. Skip, right? So this is a skip pattern here. Okay, so then we go on, and now we go into the unstageables. So how about the number of unstageable pressure ulcers or injury due to non-removable dressings or devices on the start of care? Do we have any of those? Right. How about at discharge? Right. And then how many of these were present on the sock rock? Skip. Good. You getting this? How about the number of unstageable pressure ulcers due to slough or eschar? Correct. On start of care. How about at discharge? Okay. Good. The number, so now we have one, right? So what is the number of these unstageable pressure ulcers that were present at the most recent sock rock? Right, 0, right, because we didn't have that. Okay, the number of unstageable pressure ulcers presenting as deep tissue injuries on the start of care? Correct. How many at discharge? 0 is correct. And then again, the number of these that were present on the sock rock. So what are we hearing? Skip, right? So this would be a skip pattern on this. Okay. So here's the rationale behind this. So hold on, I just got to get to. So the deep tissue injury with intact skin observed on the sock rock skin assessments first became stageable as a stage 3. Remember, so it was a deep tissue injury at the start of care. Then it told us what it was going to be, so it ended up evolving, and then we could stage it. So its first ability to stage it was a stage 3. And that was a home visit. So what happens to that stage 3 then? That becomes present on admission if at discharge it's the same thing, right? So that would be that it wouldn't be new or different. So 1311F1 is coded as 1 on the sock rock assessment. At discharge, the ulcer was observed to be unstageable due to slough and eschar, and so that's how we had the coding. So any pressure ulcer that's observed to be unstageable due to slough or eschar, but was previously numerically staged, is considered new and not coded as present on the most recent assessment. Therefore, the discharge assessment items are unstageable pressure ulcers due to slough and or eschar is coded as a 1, and E2 is coded as a 0 because the unstageable pressure ulcer was not present on the most recent assessment. All right, you guys did very well with that one. Let's go on to our next coding scenario. So patients admitted to home health with a stage 2 pressure ulcer on the right lateral knee. The skin assessment on day 6 of the quality episode identifies that this ulcer has evolved to a stage 3 pressure ulcer, which remains at this stage at the time of discharge. So admitted with a stage 2, day 6 has a stage 3. So let's look at the coding on this. So then here we're looking at the number of stage 2 pressure ulcers at the start of care. Right. How many at discharge? Right. So the next question is number of the stage 3 pressure ulcers that were present. Skip. We'll get you guys to say skip at some point. But again, if this was in a computer system, the technology would put an automatic skip pattern for you. It makes your life a lot easier, okay? How about the number of stage 3 pressure ulcers that were present upon admission? Right, didn't have any. But how about at discharge? Right. So now the question is, of that one, stage 3, that we have at discharge, how many of those were present on admission? 0. This is where we would put a 0, right? Because we're saying there weren't any of the, we have one at discharge and none of them were present upon admission. The number of stage 4 pressure ulcers at the start? We didn't have 0. And how many at discharge? 0. So the next question is how many were present at start of run? Skip. Good, you guys are getting it. All right. So now we have all of the questions related to unstageable. So number of unstageable pressure ulcers due to non-removable dressing. Right. How about at discharge? And then the next question, how many were at the start of care? Skip. Good. How about unstageable due to slough or eschar? At start of care we had 0. How about at discharge? Good. And then how many of these were present at start of care? Skip. You guys are getting it. How about unstageable pressure ulcers presenting as a deep tissue injury? We had 0 at start of care. At discharge? Right. And then number of these unstageable pressure injuries that were present at the most recent sock rock. Skip. Very good. Okay. So you did great. Let me just get to the next scenario. So let's go through the rationale. So at the start of care, the patient had a stage 2 pressure ulcer on the right knee. So we coded 1 for A1 as a stage 2 in the start of assessment. And then, of course, we know that on day 6, that same ulcer changed to be a stage 3. So 13B1 is coded as a 1, and 13B2 is coded as 0 on the discharge assessment. All right. So here's our last scenario. I think it's 6. I don't know. Do I have 7? Hold on. Oh, we have 2 more. Okay, so here we have at start of care, the patient's skin assessment reveals 2 stage 2 pressure ulcers on the right elbow. On day 5, while conducting a skin assessment, both pressure ulcers were identified to be stage 3. On discharge, the patient's skin assessment reveals 2 healing stage 3 pressure ulcers on the right elbow. So let's look at how we would code this. So how many stage 2 pressure ulcers do we have on the start of care? Correct. And then how many do we have stage 2s at discharge? Right? So then the next question, how many were there at sock rock? Skip. Right. So now the next question is the B1, number of stage 3 pressure ulcers on the start of care? Right. 0. And then how about at discharge? Right. We have 2. And then how many of these stage 3s, these 2 stage 3s, were present upon admission? Right, none of them. Okay. And did we have any stage 4 pressure ulcers? No. How about at discharge? No. So the next question would be skip, right. So none of them were present upon admission. And then we go into the ones with pressure injuries due to non-removable dressings. Do we have any of that at start of care? We had 0. How about at discharge? Right. How about any present on start of care? It would be a skip, right, because we didn't have any. How about the unstageable pressure ulcers due to slough or eschar? Any on start of care? No, we had 0. How about at discharge? Right. And so the next question, how many were present at start of care? Skip, you got it down now. And the number of unstageable pressure injuries presenting as deep tissue injuries. Any at start of care? Nope, 0, good. How about at discharge? Right. And then the number of these unstageable pressure ulcers that were present. Skip, good. All right, so the rationale here that we're talking about, so at the start of care, the patient had 2 stage 2 pressure ulcers on the right elbow. Therefore, 1311A would be coded as 2 on the start of care assessment. And then on day 5, while conducting the skin assessment, you noted that both pressure ulcers had deteriorated, now we're stage 3. And then on discharge, they stayed as they were healing stage 3, but they still were stage 3. So M13B1 is coded as a 2 on the start of care, and B2 is coded as 0 on the discharge assessment. All right, so let's look at the last coding scenario. So here we have a patient who's admitted to your home health with a right ankle foot orthosis to compensate for weakness in a foot drop. On the first skin assessment, the clinician notes a stage 2 pressure ulcer on the right upper ankle that conforms to the shape of the AFO. The orthosis is consulted and the AFO is adjusted. At discharge, the ulcer is assessed as a stage 2 and no other pressure ulcers or injuries are noted. So, how are we going to answer this? How many stage 2 pressure ulcers does the patient have on start of care? 1, correct. How many at discharge? He has 1, right? So this is the one from a device. So he had the 1. They made some adjustments, but they still had that stage 2 on discharge. How many of the stage 2 pressure ulcers that we have on discharge were present upon admission? 1, right. So here it just stayed the same. It was present upon admission, was still there at discharge, and so that's coded as a 1. All right, and then we'll go through these. How about stage 3 pressure ulcers? Right. And then how about at discharge? Any stage 3s? Right. So the next question, how many were present? Would be a skip. How about stage 4s? Right. And then how about discharge assessment? Right. And then number present upon admission? Skip. Good. And then we go through the same things. Do we have any pressure ulcers or injuries due to non-removable dressings at start of care? Nope. Nope. Do we have it on any discharge assessment? No. Number of these unstageable pressure ulcers or injuries that were present at sock rock? Skip, right, because we don't have any in the discharge. Same thing for slough and eschar. Any on admission? No. How about at discharge? No. So the next question will be skip, right, because we didn't have any. And then how about presenting as a deep tissue injury? Any at start? No. And then how about at discharge? Right. And then the number of these unstageable pressure ulcers that were present on the sock rock? Skip. So you see how once you've identified, what was present on admission, what was present on discharge, you can pretty much quickly, as long as they weren't any, like this whole back section, if you didn't have anything related to non-removable dressing or slough or eschar or whatever, you can pretty quickly go through and encode these. So the rationale for this particular one, on the initial skin assessment, the patient had a stage 2 pressure ulcer on the right upper ankle, and it conformed to the shape of the AFO. And often that's where you see where it's device related. You can really tell because you can just kind of align it with something that they're either in their wheelchair or a splint or whatever. So M1311A is coded as 1 on the sock rock. And then the AFO was adjusted. However, the pressure ulcer was still present at the same stage at the time of the discharge assessment. So you did the right thing, right? You had the brace assessed and adjusted, but the wound hadn't healed yet. So therefore, on the discharge items, 13A1, stage 2 pressure ulcer, is coded as 1, and then 1311A2, and that's asking what was present at discharge, and then of those, what were present at start of care, it's 1 because it was present there. So changes in skin integrity, post-acute care, pressure ulcer injury is a cross-setting quality measure implemented to meet the requirements of the IMPACT Act. Hence the reason of the initial skin assessment. If you take nothing away from today, again, that's the most common questions that we get. What happens if I do the skin assessment in day 3, something changes, day 4, something changes, or day 5? Why can't we change it? And the reason behind that, if you take nothing else, is that this is an aligned measure, and we want it on the initial skin assessment. So, in fact, CMS is looking at apples and apples and not apples and oranges, so that different settings are doing it in different ways. It replaces the current pressure ulcer measure, percent of residents or patients with pressure ulcers that are new or worsened short stay. So this is a replacement measure. The quality measure includes new or worsened unstageable pressure ulcers, including deep tissue injuries, in the measure numerator. So if we have a wound that was stageable and now it's got slough or eschar, it's considered worsened. The measure calculation has been amended to include M1311 items instead of M1313, and that was to reduce redundancies, and we talked about that. And revisions are informed by the National Pressure Ulcer Advisory Plan. We're just coming to the end. I think what I'd like you to do, there's a lot of takeaways from this session, and hopefully I hit upon those most common questions that have been asked over and over and over again. And if we're getting it from this group and from the audience who's taken the time to go to these trainings, can you only imagine what your staff out in the field are going to have these same questions and not understand? Because they'll say, well, it doesn't make sense. I have 5 days to assess. Why can't I change that? So part of this is deeming people competent, making sure they understand the why behind things. I'm always one of those people, if I can understand the why, it just makes it easier for me to conform with the rules. But if you take out your action plan and jot down some of the ideas and thoughts about what you can do when you go back to your organization and share, or if you're online, that you can share with your staff that you learned today, whether it be from this session or any one of the sessions. All right. So if you take the minute or two that we have between sessions now to just jot down those ideas, it's easier if you jot as you go. By the time you leave, you actually have a plan, an implementation plan that you can bring back to your organization, discuss with leadership, and then go ahead and implement. Okay. All right, I'm not sure who comes up after me. Oh, I didn't see you, Charlotte. Okay, Charlotte. So Charlotte's going to take the next session.